So, yeah, sure, I would love to not have to do what we do, but it's
This
reality.
question may be a little bit offline, but we've had no one here from Massachusetts yet, so I'm going to use this opportunity to ask you, since they are in the implementation process of a system somewhat similar to what we're debating in this committee, what's happening there? If you could just make a brief comment.
Well, we're still recovering from the Red Sox loss in the division series with the Angels, so I'm a little still teary-eyed. I don't know enough about what you're proposing here to make a comparison, but the fundamental issue they did in Massachusetts, Governor Romney did, was to make health insurance mandatory for everybody to buy and to create a system that would a statewide exchange to allow insurance companies to provide policies that were cheap enough for people to afford who couldn't afford it. They have not addressed the cost issues that a lot of people are complaining about, and we've been talking to them about these types of issues as well, saying we have to get our arms around real and immediate impact by improving the quality of care.
Thank you.
Mm-hmm.
Representative Siegel.
Thank you, Madam Chair. And if I can have a couple of questions, if that would be okay. I just find this very interesting. On a whole, I had an opportunity to do some work with delegations from other states on healthcare. It takes about 17 years to get from a best practice and a study being published till when most doctors are implementing it. And that is a huge problem. But I'd agree with Representative Pavlov that we need to look at why it's taking that long and that side of it.
Yep.
And because my concern is, with your Ruth example, and it said in your testimony, we ask you to sign a release that authorizes the collection of all your data. Are you a for-profit company or a not-profit?
For-profit.
Do you have to follow HIPAA? And then what other restrictions are there? I mean, you're a multinational company collecting every piece of information on individuals. So
yes.
You can answer that part.
HIPAA applies to the work that we do, and the reason we get the release, I mean, of course we build into it things that say you understand what we're doing, and the employee knows what we're doing. They've called us voluntarily. In other words, no one tells them they have to talk to them. We refuse to participate in those situations. But with respect to the data we collect, that's kept absolutely positively confidential and used only for the purpose for which we collect it. So we don't sell any data to anybody or use it for anything other than to help you with your medical problem.
And you have really good security then.
You should see what it's like when you have a client, like I mentioned, Northrop Grumman, a defense contractor. You're pretty secure.
Now, in the example you also gave, you said you shared what your clinicians and your experts found with the doctor. Does that also get shared with the patient?
Oh, yeah. The patient is the person that we engage. Okay. So remember, they call us. And one of the things we'll ask them is, do you want us to give this to your doctor? Now, we want them to, because we feel like information that just gets given to no place where it can have an action taken is wrong. But it's usually interesting to ask, would you like us to share this with your doctor? Because it often leads to a question of, actually, no, because I'm not comfortable with my physician. And now you're in an interesting conversation. But in whatever situation there is, what we want to do is have that information in front of the patient with their doctor so they can pay attention to it. In a case like Ruth's, she needed to have surgery done. And it can't be that the file just sort of disappears. This needs to be in front of her physician to help decide what to do. So it's a very important part of our work.
And you just said that you don't participate in plans that would require an employee to call you. But
right.
Do any of your competitors do that you know?
Well, it's a complicated market out there. There's people that are doing things like disease management is a very popular, or used to be a very popular trend in healthcare. And that was all about, let's look through claims data and let's identify people who could benefit from our help. And then they have people actually make outbound calls to you. Some of us, anybody in your family has any kind of chronic illness, whether it's asthma or heart problem or high cholesterol, may have received a call one day from a health plan saying, hi, I'm here to help you to manage your illness. Speaking from our research, people don't like that. They find that intrusive, and the immediate reaction people seem to have is they wonder what your agenda is. I mean, they're there to save money. I mean, they're helping people, but their primary purpose is to save money. And I think that relationship of trust is so important that approach to doing this is not the wise way to go.
In any of the other countries that you're participating in, are you standard in any country as, because they have nationalized healthcare? Are you part of any of that?
Well, Canada is is sort of the gold standard of nationalized healthcare, since that's what there is. We cover about 4 million people out of the 30 or so million in the country. Most of those people we access through their employer, just like in the United States. Employers still provide lots of health benefits. That said, we contract with government employers as well as a way to get at individuals. But it's again why it's important to remember that distinction between health care and health insurance, and the idea that if you get the health care right, you save money on the health cost. And so it works in any market.
And just the last point on that one then, with all your experts that you're working with, what are they basing their diagnosis on? Are they using the latest and greatest best practices? Are they doctors in the field?
Mm-hmm.
I mean, who are these people? Why should that diagnosis be the better one than the one the doctor gave?
Excellent question. So we have, for the last 20 years, been developing a peer-reviewed database of doctors. And we've been surveying, and we do it pretty much every year, doctors within each specialty area, and asking them to tell us, who do you think are the best within your specialty? You see it published. Some city magazines publish best doctors lists. Some of those come from us. I think Detroit Magazine did one recently, and that was our data. So what we have is, it's not sort of the end-all and be-all, but it is almost a snapshot of the reputational landscape of medicine in America. Who do doctors look up to? So it means that we know we're talking to people that are specialized in the specific problem that's being dealt with. But the really important thing is that work we did at the beginning, like in Ruth's case, to say, what does it mean to have an inconclusive result in a biopsy with thyroid? Now, a lot of people can answer that question, but the first thing to know is what question to ask. And that was the key to her case. But the experts are very renowned people that are all practicing and board certified and all those things.
Thank you very much.
Representative Janeski.
Thank you, Madam Chair. Appreciate the testimony today. I'm looking in the charts section of the book, Louis. I'm looking at number 4, Best Doctors Results from 2008. And I'm wondering, surely from a patterns perspective, you've got provides direct and immediate impact on care. You've got 22% change in diagnosis, 61% change in treatment. What do you have any results for us as far as what was being misdiagnosed the most?
We do have some data on this. It's very interesting. The cancer cases have the biggest issues with this, and there's specific kinds of cancers that are particularly hard. And I'll give you a simple example. Sarcoma, which is a very serious form of cancer. There are apparently, well, if you had asked the question 10, 15 years ago, how many different kinds of sarcoma are there, a doctor might have told you 10. If they ask a doctor today, they tell you there's 60, okay? So the increase in technology allows doctors to differentiate among 60 different types of disease. And if you only think there are 10, I'm not disparaging doctors, but if you only know that there are 10, it's very easy. If you're lucky and you got one of the 10, that's good. But if they think it's type number 7, but it's type number 43, and the treatments are different for these two different things, that's a big deal. Sarcoma is the one that I think has the highest rate of issues with this. There's been published literature on that. We know that when we have a person call that says they've been diagnosed with sarcoma, we better make sure we pay real good attention to the pathology because of that reason.
Thank you. Thank you, Madam Chair.
Representative Milton.
Thank you. Thanks for coming all the way over. The cost, what was the cost again that you charge?
Oh, about depends on the size, about $3 or $4 per employee per month.
Okay. Have you found that you actually, that the folks actually save money by spending the 3 to 4?
Yes. We, in our experience, I quoted that in general, on average, in the short term, about $20,000 per case. So the savings is going to depend on how many people you get to use it. But it's not uncommon among our customers to see certainly cost neutral, but more often a 2-to-1 or better ROI on the program.
Is any of that in here, of the stuff you've given us?
I mentioned the 20,000, but I could show you I can send some of our data to you as well.
And I assume by when you say size that the more employees in the pool, the better price that you give them.
Right. Yeah. No, not height or anything like that.
What's that?
Yeah, size, number of people.
Right. So the bigger the pool, the cheaper the price.
Absolutely.
Thank you.